Okay. So for context, this is SSF, so you have people from all medical schools.
Yes, all the universities.
Okay, that's perfect. I guess you could are you going to record? Okay, fine. If you're recording, that's fine. All right. My name is Dr. Michael Magoha. I'm a consultant neurological surgeon and lecturer at the University of Nairobi. Uh, I I do a lot of work in neuro-oncology, neurological infectious diseases, and neuroendoscopy. Mm. Um, that's not to brag or anything. I've been working for about 15 years, and thank you for having me. So I'll go through this again. Please write something in the chat so that I can answer questions at the end. So as a lecturer, uh, about four things. I'll tell you what I'm going to do first. So there's going to be why neurosurgery, what is neurosurgery, how do you get into neurosurgery, and then what happens after that in neurosurgery. So the why neurosurgery is quite funny because anybody who thinks they're smart in medicine always wants to come and do neurosurgery, but they never have any thought process of as to what it is. They don't have any idea of what the subject entails or what the work entails. They think it's just about surgery and, being fun and being exciting, but that's not exactly it. And every year we get this, sorry. So as we talk about this, I want everybody to note one thing. As we keep on moving, you really don't need to know. You don't have to know what you want to do in medicine at all, especially at this point in undergraduate. I say this because I myself, sorry, somebody's letting people in the waiting room because they keep popping up. Hello? Confirmation from someone? Am I speaking to myself again? Hello?
Hi, Dr. Magoha. No, we can hear you. And
Knows what.
I've been schooling in this school ever since I was little, since baby class. And believe me, it's been a long journey. Getting these marks, it took a lot of hard work, dedication, and discipline. Not every day you see somebody coming out of nowhere and getting good marks like this. You see these marks. When I began, actually, let me tell you the truth, I never thought I would reach this far. This is all thanks to my teachers, my parents, and the Almighty's blessings. I would like to go to Kenya High School, and when I grow up, I'd like to become a neurosurgeon.
Okay. I put this because everybody here is used to seeing it every year. What's funny is I started with KCSE, but I realized many of them might end up being in this group, and I didn't want to offend anyone. But at least I can say this. In my years of teaching, I've never seen one of these people come and be a neurosurgeon. And that might be for many different reasons, and it helps illustrate the point that we're saying. Neurosurgery seems to be visible compared to some other specialities, but I don't think there's anything special about it. Uh, about it in terms of you have to be a special character to do neurosurgery. I don't think that that exists. So as we do this, as we continue,
My name is
I'm going to show you a couple of things.
Kawera.
Sorry, keep popping up.
In
So the other reason is because of this gentleman. I don't know if he's still exciting to you guys. At some point, I'll realize I've aged out. So everybody seems to know, Dr. Derek Shepherd and McDreamy, and they think what you saw on Grey's Anatomy is anything close to being a neurosurgeon. I mean, not at all. In fact, I would wonder why he has so much time. He has so much time to have so many extracurriculars as a neurosurgeon. And frankly, he looks a bit too fit to be a neurosurgeon on a lighter note. But the point I'm trying to make is neurosurgery is it's a lot deeper, a lot more intense, and I think you get a lot more complex characters than this gentleman that you have in Grey's Anatomy. So I don't think he's a good reference point. And the next thing I have is this gentleman. Does anybody know who this gentleman is? Somebody can unmute and talk. Anyone? There's no wrong answer. It's better if you participate. That way I know I'm still here and I'm not presenting to myself. Anyone? Any idea? Any guess? Anybody want to type it in the chat? Are you even here or did you guys just join?
We're here, Doc.
Anyone? Nobody knows who this is. Okay. This is Noam Chomsky. Yes, Dr. Kamande. Go
I
on.
actually wanted to say no, Chomsky.
Okay. No, since you said Noam Chomsky, do you know anything about him?
Um, not really,
Any?
no.
Huh? Say again?
Not really, no.
You don't know, but you know his name. How do you know his name, but you don't know who he is?
Image search.
Image search. Okay. Smart man. Smart man. An honest man. Honest men you can trust. So you're right. This is Noam Chomsky. I would call him one of my heroes. I'm sure he has no idea about me, and that's fine. But as the story goes with Noam Chomsky, he was a virtuoso, a real Renaissance man, and he was quite smart. And he finished, I think, high school and his first degree extremely early. I forget the exact year. You can find this out for yourself. It's, I think, about at the age of 16 or so. And at some point in his life trajectory, he was offered placements at every Ivy League university. And as the story goes, he picked MIT and he was allowed to start any department that he wanted. Imagine the power. Imagine how smart you have to be that everybody wants you and they say you can start anything anywhere. And what he did at Massachusetts Institute of Technology is he went and started the linguistics department at MIT. And that department to date is still one of the highest earning departments at MIT. And that sounds funny. He went to do linguistics at Massachusetts Institute of Technology. Why? Because he had foresight. And the one thing he kept saying is the power to communicate is the most powerful thing that we have. Now, a few years ago, if I told you something like this, you would think it was corny or it was fake, or what does he mean power to communicate? But you realize that what he had was incredible foresight because nowadays, he is he's right on track because of LLMs, large language models, and you realize the ability to communicate with things that you might not understand is infinitely more powerful. And there you go, he was right. But the reason I put him here is with regards to what we're talking about is this simple thing. He has a quote which I like, which I always tell students when they start asking me questions and they start saying things without fully understanding what they're talking about. And the quote is this: beware reality versus the abuse of reality. And that's a very important quote because to the uninitiated or the uninformed, a very little information seems extremely powerful. And those with very little information tend to get distracted extremely easily. They're unaware of things which are happening. They're unaware of what is going on. And because they feel like they know, they are easily distracted. And one of them is neurosurgery or postgraduate medicine or anything as a whole. And I put this here because given the current climate, what's going on right now, there seems to be a bit of an air of doom and gloom or hopelessness. But even with what is happening, nothing new is happening. It's not the first time youth in Kenya have been rioting from anything. You know about Saba Saba, you know about the previous people. It's not a hopeless situation. We have gone through it before, we've gotten out of it before, and we've learned from things before, but only for those who actively take part. That's one thing I want you to be aware of. So, what is the reality? And if we're going to talk about reality, reality has to start at home, just like charity begins at home. And when we talk about reality, we have to talk about Kenya. And what do you know about Kenya? It's a beautiful country. It's on the equator. The food tastes really good. Things are so much cheaper than everywhere outside. And in the region, we're actually quite ahead on many things. But the way if you speak to young Kenyans, you'll think that we're not. And what does this mean? Pause, think. It's a country of 55 million. In this country of 55 million, more than 75% of the population is below the age of 30 years. It's either 30 or 35. You can check the KDHS. And in that value, about 55% of them are less than 15 years. So we have a burgeoning young population. So where does that put you right now, the medical student who's trying to figure out what to do for your postgraduate? This is basically saying you are the one to move forward. You're the one to effect change. You're the one who can change everything because the rest of them are going to die. There are going to be very few skilled, educated people who are going to have to take over. And that at this point, some will be saying, but doc, things are thick. Wow. Imagine people are not being hired. They're not getting jobs. It's not like your time. You have no idea. You don't understand what's going on. Well, let's understand it together. In this country of 55 million, in 2022, there were 9,638 registered medical doctors in this country. That's a ratio of 19 physicians per 100,000. That's a population of about 55 million. Now, this number keeps going up and down because if you check some sources, they will say there are about 16,000 doctors. If you're on the news, etc., they try and make that number sound big, about 16,000 doctors. But please look at this, registered medical doctors. So there are many who will graduate, some will not practice, some will die, and some will retire. But as of 2022, there were only 9,638. What other thing is important to note? So if you check this study, this is BMJ Global Health, and they're talking about investing in the healthcare workforce in Kenya, the trends in size, composition, etc. Now, with all these questions, whenever one of you comes to me, you say, oh, neurosurgery, I want to do it because there's so few of you. And I just smile. Have you looked at your country? So if we look at that same exact study, you get this number of qualified and registered, which is 12,792. So this study is better and more stringent. This was in the year 2020, and this came from what we used to call the board. At that point, there are only 12,000 who are registered. Now, of those who are registered, about 8,000 of them are medical officers. Now, you think there are few neurosurgeons, but keep looking down. There are only 28 dermatologists in the country as of 2022. There are only 402 obstetricians and gynecologists, only 104 ophthalmologists who are registered and working in this country. If we keep going, there are only 343 pediatricians. There are only 347 internal medicine specialists. And that is internal medicine. It's not dividing it into neurology, etc., rheumatology, not that. That's in total. There are only 70 psychiatrists, only 140 radiologists, and we come to surgery, there are only 332 surgeons. So immediately, what is the first thing that comes to mind? You have space. That's the first thing I want to get out of your head. Internship is such a small part of your journey. You have a lot of space to do a lot of things. The next thing you wonder is, but why paid to tell you bad news? The second thing is you need to understand that the degree itself does not mean that you will be hired. Are we together? It doesn't mean that you will be hired. And it doesn't mean you will be hired where? You will not be hired in places that have already established systems, big established systems, unless you have something special to provide apart from your degree. And that's simple, common sense. If you're a student in Kenyatta, you will not be hired in Kenyatta, or correction, it's unlikely you will be hired in Kenyatta unless you have something to provide. Because every day there's a new crop of students. But if you open your eyes and just look down the road, there are so many opportunities where you can work. Another part which is forgotten is there's a lot of things that you can do with your degree aside from straightforward practice in a hospital. If any of you have traveled, if you just work in the hospital, you are called a hospitalist. So hospitalist is just one grade, one job. It's not the only thing that you can aspire to. So let's think about that again. Only 332 of all of those different specialities in this country of yours right now. So if you just want to be a surgeon, you have a lot of space. Surgery is going to be needed everywhere, not just traveling to 3 or 4 hospitals. Here's another fun fact about Kenya. With all the things that we have, all of these hospitals, to date, we still do not have a functioning pre-hospital system. So what does that mean? It means we can't connect people to different places. So what is that? It sounds like a simple thing to me. Sounds like instead of there being a problem that you won't get a job, that you can't be hired, it sounds to me that you have ridiculous opportunity compared to other cadres. It sounds to me that if you're thinking of quitting medicine to go to another job, it sounds like you're stupid because I would rather be fighting with only 9,000 people than going into a field where you'll hear there are 800,000 to 1 million people I'm trying to distinguish myself from. And they had a head start from me. So with simple maths, it's common sense that you're in a good field and you have a lot of opportunity. The issue is you have to find where the opportunity lies. That is the thing I want you to start thinking. As we keep going, find where the opportunity lies. If you think it's just neurosurgery, it's just because you've only met a neurosurgeon. Another thing I should say is, if I'm speaking to students who are in university, there's one huge problem. Most of the people you see who are successful are only going to be lecturers. Now, what you might be forgetting is a lecturer is also a job. So whenever you see a lecturer in front of you with a specialty, you're seeing somebody with 2 jobs. So you've already seen a different route out. That being said, once you leave and you go into the world proper, you will see all of the other graduated people who are doctors with ridiculous opportunity, working, living, thriving, making a lot more money than you have ever seen. And that's because they saw other things to do. So I hope that point is taken well. Now, this is a simple thing I have to say. I'm duty bound to say this to all of you. If any of you ask, how do I become a surgeon, a neurosurgeon, etc.? The first line is this that you must hear from everyone. If they do not tell you this, they're either lying or it's bravado or they're just trying to seem important. If you're interested in neurosurgery, you might have been told by friends, family, peers, because they know this surgeon is very successful, this one is a nice guy, this one drives a nice car, this one lives in a big house, any of that nonsense that you hear. Yeah. Even from neurosurgeons themselves, that you should pursue any other field. As with all pieces of advice, make sure you assess the context and the intentions of whoever has given you that advice. Always take their advice with a grain of salt. And the other thing is remember who you are and where you're coming from, because what you have is going to be different from what others have. And you have to go and find that out. So nothing anybody tells you is the gospel truth, including myself. All I can tell you is how I got into it myself, the pros and cons, and how I have seen other people who have gone through it. And even if I tell you how other people have gone through it and have arrived, it should be taken with a grain of salt. Sorry, did I cut somebody off? Okay,
No, you didn't.
okay, thank you. So here's another simple one. If you're planning on picking a specialty, here's a common sense thing which I think students always forget. Number one, non-medical advice is 1,000 times less serious than a surgeon's objective experience. Please note, I've said objective and I have said surgeon. That includes speaking to residents. That's the part students forget. You can speak to a resident of how to reach there, where they have reached, but do not ask them about the life because they have no idea about the life. They're in training and they have no idea. They haven't gone out to start working as that thing that they want to become. So they do not know. Are we clear? The simplest way of saying it is, it's if a high school student comes and talks to any of you here in the forum about being a doctor. All of you have no idea. You have different stories, you have different versions, you have different feelings. But until you work, you don't know. And when you start working, all of your experiences are going to be 100 times different. So please remember that. The next thing is the best advice applies to personal circumstances. And for that, I will give a personal story of myself. When I was an intern, I'll skip many parts. At some point, I decided I wanted to be a neurosurgeon. So after you decide, comes the other things like payment, etc. Now, when I went and saw the school fees structure, and it's not that different from now, you might say it's different. Yes, the amount has increased, but at that time, that amount was extremely ridiculous to me. I only had enough money to pay for the first 2 years, but to join, you have to have enough money to pay for the whole course. So what did I do? Now, you might think, because you might have heard my name before, you might have thought it was very straightforward. I just go and ask for the money. Well, that's half true. That's half true. But the funny thing is, you don't know my personal circumstances. You don't know my family. So, and the one thing that they would say is, if you want something, you need to go and prove that you want it. So go and find out, because if you're spoon-fed, how will you survive? And that simple thing. So I went, I had no idea what to do. I spoke to many mentors, I spoke to many people, and I said one simple thing. Hi, I don't have enough money for this. Do you have any ideas of how I can make money to get this? Then, and I was told very simply from one of my mentors, why am I thinking about making the money? There are other options. There are many options which you will learn. And this was my time. Your time is even different. There's more opportunity. And I say there's more opportunity because I do sit and review people who do come for interviews. And many people tell me different stories and they do many things where I was like, wow, I had no idea. You're very smart. But for me, when I spoke to people, I learned that there was something called a tutorial fellow. I had no idea what that was. And when I asked my peers, or slightly older than me, what a tutorial fellow was, all they told me was a lot of nonsense. That same thing dissuaded a couple of people. Another thing I must tell you, do not do anything in medicine alone. I do not know any of my seniors who have gone up. All of the ones who have done things I want to do, none of them do it alone. I don't know where this new attitude came. It's a generational thing. You want to do everything by yourself. You don't ask for help. You want to be seen as in charge yourself. It doesn't work like that. You'll just be stressed for nothing. But when I went and I spoke to different people and I was explained to by the people themselves, I found out that they will train you as long as you don't fail exams, and they'll also pay you. So I didn't know that that existed before. And that's one example that I'm giving you. So consider your individual situation and value others' experiences. If you hear something, take it with a pinch of salt, write it down, go check for yourself because you are not them. And remember, different experiences will differ from personal ones. The perfect example that I will give is many students say, or I don't know if it's still said anymore. There was a time where you used to say, don't do your internship in a private hospital. You wouldn't get to do anything. And I would laugh because that's a stupid generalization. I'll give an example. I was an intern in Aga Khan. I got some of the best surgical experience, one-on-one with some of the best surgeons who sat me down and spoke to me. That's my personal experience. In the same internship group, there was the one girl, I remember her to date. I won't say her name. I hope she's alive and still practicing. She caused so much drama. Every day there was a problem with her. She couldn't even do a call. No one would call her to theater because all she did was make noise and cry. She's the first time I saw it, but I hear it happens a lot now. Somebody who the parents came to complain that she's being overworked at the hospital. I thought that was the most ridiculous thing. You finished university and your parents are coming to complain that you're being overworked. And there was nothing special she was being given. In fact, she had less calls than everyone else. Now, if you spoke to someone like her, she will say she didn't get to do anything, but that's because she was no fun to work with. No one calls people they don't want to work with. And that's the point I'm trying to make. Even though you hear one single experience, diversify it so that you can make an informed decision. Now, in the same thing, it's better to enjoy life because selection is just temporary. At this point, you might think deciding what to do is such a big deal. Like you have to do it. Like you have to know. When you finish, it's just going to hit you. You'll see a baby crying, and next you want to be a pediatrician or some nonsense like that. No, that's not really how it works. I'll tell you a personal story that my father told me when I was in the same situation. Uh, my dad, for context, was a world-renowned neurosurgeon. I mean, no, urologist. And I say world-renowned because it's there to date. You can check. There's this book called The Who's Who in the World. It used to come out every year in the beginning of internet and after that. And in the Who's Who, people vote, people who have done change for different things. And my father was in that book for like 2, 3 years in a row. So basically, the world is agreeing that amefanya kitu. And he was a urologist. Now, the funny thing is, anybody who met him as a urologist would think the same thing, especially the younger ones. They're like, wow, this guy just knew what he wanted to be. Oh, sometimes people just know, blah, blah, blah. Well, no. He told me, this is how he decided to be a urologist. The best dressed person in the hospital was a pharmacist. The second best dressed person was a urologist. So he started urology. The only reason he continued urology is because he realized, well, actually, there are not that many emergencies. You can put a catheter and come back the next day. So he loved the life. He didn't know what he was doing. Hello? So, yeah, so he loved the life. He didn't know what he was doing. He didn't know what he was picking, but he liked the work ethic and he continued. He didn't have to know everything about it. And as you're picking your postgraduate, you can move in the same vein. Wherever you go, you will be needed. You need to go and see where you are needed. If you like the work ethic and you like things, it doesn't have to define your life. Learn to separate what you do for money versus what you do for yourself. So, what's neuro? To me personally, I think it's pretty cool if you like brains and spines. But for context, I hated neuroanatomy. The other thing is my first neurosurgical procedure. My first neurosurgical procedure, I was thrown out because I hadn't read the file in detail before. By that, I did not know the patient's RBS before theater. And I thank that neurosurgeon who threw me out because he changed how I managed patients. The second time, I fainted. So I was like, I'm not doing neuro. And this was during internship. Like, there's no point. They stand for too long. The people seem to be mean. I don't want to be in this thing. Because I had no idea what neuro was. I went to find out, but I didn't find out properly. But how did I end up doing neuro? Well, I hated neuroanatomy, but I was good in neurologic exam. It's honestly that simple. And I was seen by Professor Joey at the time, who pulled me to the side and asked me to join his clinic. And then I saw, oh, these diseases are pretty cool. Can I have these diseases with a bit more blood? And it's honestly that simple. So there's a picture of someone here. You don't have to reverse image search this one. This is Harvey Cushing. So Harvey Cushing is renowned as the father of modern neurosurgery. This is like 40s, 50s, recently, and he's responsible for many different things, many different advances, being part of a team for multiple things. You can go and check from like the Bovie to cautery to many different things. Now, around the same time, Harvey Cushing was recording his 2000th operation. There's a video online that you can check. Around the same time, if you go and Google, you can go Google this, Google historic neurosurgery Kenya, and you will find men in Kisii who are doing traditional neurosurgery. At the same time, Harvey Cushing was doing neurosurgery. So what does this mean? Why is this important for all of you? This is important for all of you because some of you, when you talk, you think things are better outside, like they discovered everything outside. You don't see the opportunity that you have. And at the same time, The only reason you know about Harvey Cushing is because he published and he's a draftsman. It's not that he changed everything. Yeah, people were doing things, but he wrote it down. He wrote it down. A draftsman used to draw different things. He had many detailed drawings that he did. And one of the funny things is the father of neurosurgery himself is a well-known artist and writer. That's the point I'm trying to make. He is known because he recorded things, not that he read and studied and changed this, etc. It's because he recorded what he did and he took pride in what he did. And that's all you have to do if you want to be a good neurosurgeon. And at the same time, when that was happening, we were doing things which we just didn't record and didn't write down. You might wonder, how do we know about these cases? We know about it because the University of McGill came and recorded at the same time. So they're the only ones who have the record of that. The rest of it is word of mouth. So now that you know about the father of modern neurosurgery, you know that he was a writer, he was an artist, he recorded what he did. Let me show you something about the 5 tenets of neurosurgery.
Neurosurgery is a medical specialty concerned with the prevention, diagnosis, treatment, and rehabilitation of disorders that affect the entire nervous system, including the brain and the spinal cord. Kenya.
We do have a huge burden of brain tumors. As a matter of fact, brain tumors are some of the commonest tumors in human beings.
So if you thought about Kenya, you'd need to have probably 160 or 200 neurosurgeons at least to handle the 40 billion.
18 students are currently taking the course at the University of Nairobi.
Earlier numbers, there's only 37 of you in this country. I mentioned it yourself. There's a huge shortfall of neurosurgeons we have. 37 for a population of 50 million ni ratio kidogo sana.
1% to 1.4 million.
1 to 1.4 million. A collaborative team from the University of Toronto to teach us advanced techniques of doing advanced neurosurgery. Enough experts. He also says in case there is a mass need for this service, then there is always an alternative.
Many of our students right now are very easily able to do basic neurosurgical evacuations by the second year of their training.
Yeah. In case the patient experiences seizures, among other neurological complications.
Yes, she will be Kenya's first female neurosurgeon. To her, this is the most fulfilling career.
Motivation is the fact that you can finish the mission to be able to move with one patient.
This is 2 days. Then 28 to 34 weeks, which is what's most commonly reported. Child develops an infection after meningitis.
We found out that the head injury alone, right? Head injury alone kills 56% of the patients with severe head injury will die.
Okay, so what that video showed you is there are about 5 tenets of neurosurgery, which would be the daily work. So the first one is general neurosurgery, where you do a bit of everything, and we still need a lot of those. The other one is spine. Then we have vascular. We have functional neurosurgery, which to date has still not been set up in the country at all. So we manage a bit of spine procedures. And the point I say about setting up is if you pick a discipline where there are few of you, it doesn't mean that life will be easy, especially living in the country. It means it's going to be a bit hard because it's up to you to set up and establish the systems around practicing in that discipline. And like to date, functional neurosurgery is not there because you need a lot of infrastructure support. An example is microsurgery was not possible until there were microscopes, and now there are microscopes popping up everywhere. So whatever you pick, as long as you go deep into it, you will find there's a need for more. Then there's pediatric neurosurgery. Kenya is one of the meccas of pediatric neurosurgery, thanks to Professor Albright. Professor Albright is a world-renowned neurosurgeon, part of the AIC Church, who at some point later in his career moved to Kenya, and he moved to Kijabe. And he wrote what we consider the Bible of pediatric neurosurgery that everybody reads. And he keeps saying in his book, when he moved towards the end of his career, in 1 year, he operated on more patients than he did in his career of spina bifida, and he completely changed the management of it. And to date, we still have people coming for a quote-unquote pilgrimage, especially from the United States, to see what is happening in Kijabe, so that you know that, I only say such, you know your country is one of the places. The other place that has a lot of neurosurgical interest is Uganda as well. But they're slightly behind regarding infrastructure, but I know that will change. So I'll give you an example of each of them so that you to just set the tone. Let's skip this. Oh, doing it again. Apologies. Let's see if this one. Okay. So this is an interesting, this is just reminding you that we do spine as well. And please don't forget, the country that you're in right now is at war. It's still at war. And this is one of the soldiers who received treatment, not a Kenyan soldier, though.
Explosion caused by.
What's going on?
Dr. Magoha, and I'll be taking you through today's case, which is a left parietotemporal glioblastoma.
Apologies, I skipped one. So do the neuro-oncology first.
Previous craniotomy presents with a 6-month history of headaches, progressive hemiparesis, and sudden onset aphasia. Examination revealed a woman with a Konofsky score of 60%. GCS was 13 with right-sided hemiparesis, which was 12 to 5 at the Medical Research Council grading. She also had a right upper motor neuron facial nerve palsy. Revealed a large, ill-defined temporoparietal lesion that was hyperintense in T1, hyperintense in T2, with variable gadolinium enhancement. It had elevated signal and diffusion-related imaging. Choline, lactate, and lipids were increased, with a decrease in NAA and myoinositol on spectroscopy. For preoperative planning, we were targeting the superior temporal gyrus and inferior parietal lobule. We planned to do a standard temporoparietal craniotomy using the previous craniotomy line. We elevated the scalp in a single layer using the previous trauma flap. Good healing of the previous craniotomy line necessitated a new craniotomy using a high-speed drill. The cruciate durotomy was done, exposing the superior parietal lobule, inferior parietal lobule, and superior temporal. During corticotomy planning, it was noted that the tumor was already pointing and egressing through the superior temporal. This diagrammatic representation shows the extent of subcortical resection we were planning. As the tumor was in the dominant hemisphere, we elected to use intraoperative neuromonitoring. The modalities we used were somatosensory evoked potentials, motor evoked potentials, and cortical mapping. soft suckable regions of the tumor or resected via sucker dissection. The grittier and nodular regions were resected via piecemeal resection. Intermittent cortical mapping ensured that we maintained a good oncofunctional balance. We achieved a gross total resection. Post-operative imaging showed satisfactory resection. Preliminary histology showed nuclear atypia, cellular pleomorphism, evidence of mitotic activity with a diffuse growth pattern and microvascular proliferation, all features in keeping with glioblastoma.
Okay, so that was an example of neuro-oncology. And one thing to note, uh, sometimes we get gunners, for lack of a better word, who want to come to neurosurgery and they want to be the boss. They think they're going to be the one in charge of everything. Now, when it comes to things like brain tumors and neuro-oncology, that's not the case. In fact, the brain surgeon is not the most important person in dealing with a brain tumor. Everybody has a role to play, and the team is quite important. In fact, I'd argue neuropathologists is the most important person, because after we remove the tumor, it behooves the neuropathologist to find out, to go do genetic mapping, to do all of these tests, to find out what the tumor is going to respond to. I'm dumbing it down because I don't want to give you a topic that you're going to go and read in undergrad and get stressed about. But we still need pathologists. We need a lot of pathologists. After the pathologist has done his job, then you see if it's either going to the medical oncologist or the radio oncologist. You saw internal medicine physicians are still few as well, in the 300s. We need neurologists. I think they're still less than 10. So we have a lot of space for specialities and subspecialties. And I say this, if your only impetus to do neurosurgeries, you think you'll make money, I would argue you would make a lot more money in other fields. There was a time if you were a cardiologist, you would make so much, and I'm sure it's still the same. Hospitals have been started by cardiologists. Hospitals have also been started by neuros. But the point is, there's opportunity. From that, I think now we go to the spine. If you have questions, you can write them in the chat. I will answer them after.
I'll be taking
There's
you through today's case.
there's nothing worse than being embarrassed. Okay, yes. So this is what I was talking about before. This is a gentleman whose car was hit by an IED, and he got compression of the spine.
Patient today is a 54-year-old male involved in an explosion caused by an improvised explosive device, where the vehicle was lifted several meters off the ground and rolled. He sustained significant axial loading to his spinal column. Imaging revealed compression of the cervical cord noted at multiple levels, with critical stenosis of the exiting nerve roots also noted at multiple levels. Given the patient's presentation and symptomatology, we elected to do a 3-level anterior cervical discectomy infusion from C3 all the way up to C6. We elected to do a single horizontal incision at the level of the thyroid cartilage with good subplatysmal dissection and prevertebral dissection. We were sure that we would be able to expose all 3 levels adequately.
See over here, it's a cartilage. It's very good. Skin incision will be short. This is not the it's looking this has on the trapezium now. section now anterior. This should be 3C4. You notice an anterior hematoma. Just go to the final ligament. We're about to do a transverse incision and confirm the location using image intensify. Bring square in low. Okay. You can see. Yes, that's more like 25. Look at that. We're just checking it. It looks good. There you go. Good job. The prepared page is already put inside. Fantastic. Put it inside. Fantastic. Agree with that. Let's tighten up. It's 1 hours. Screen. Patient had an uneventful postoperative course with complete restoration of bilateral upper limb power. Thank you for your attention and have a blessed day.
Okay, and that's just an example of some of the spine we do. A simple rule of thumb, there's no fight between neurospine and orthospine. It's historical. It's a joke because some places you do a spine fellowship and you can enter as either an ortho or a neuro, but you should be able to do at least in neuro, except if it's a complex spine, and complex spine has a definition not for today. But a simple rule of thumb is if it involves the spinal cord itself, then it's going to be neuro to deal with it. If it involves the bones mostly, then it's going to be ortho to deal with it. Fun fact, remember I said there's no competition. Everybody works together in the real world. So in real life, every spine case, a neurosurgeon has an orthopedic spine surgeon that he likes to work with, and we work together. Because why? The patient benefits. You get the best of both worlds. So you don't have to fight to be everything yourself. Okay, the next one should be the reason people come to Kenya, which is, sorry, I will move a bit fast so we can finish in time. So this is a nice case too, because sometimes students wonder why you should pay attention in embryology. It's because of this, because you would see normal anatomy. So this is this plastic brain, and it looks like a placode which is going to the skin. It's not normal brain. But if you don't understand that, you'll think we're amputating brain right now. But you can see there are no sulci, there are no gyri. You can see some mesenchymal elements. That's not pus. So these are some of the things that you see if you do neurosurgery. I hope this is useful. Okay. I don't know what's going on here. Okay. Now, I put this picture here for a couple of reasons. One, for everybody to understand, as you're picking your specialty, it's not just to be the boss. Anybody you see who is successful, anybody who is doing anything, they're not doing it alone. As you can see here with the cases, this is the team that we had together. Some of these I have seen from undergraduate through to postgraduate, and some now are senior consultants, which is exciting when I see this picture. But the point is, nobody does it alone. Pick a team you can work with, and then you move. If there's friction in a team, you can always change a team member, but only when you understand why there's friction. Now, I'll speak about these people later because of the things that they've done when I tell you how to be a neurosurgeon. All right, what are the advantages and disadvantages of neurosurgery? So let's just go through this together. So the advantages is it's still one of the quote unquote real specialities. By that, I mean a lot of the caseload is going to be sick people. Even from those that I've shown you, if you pause to actually think about what you've just seen, it might not hit you because right now you might be depersonalizing. You might think it's just a disease, but not to personalize it, not to be sentimental, but actually think about the point at which you're intervening. The first one was a patient with glioblastoma having a redo surgery. So if we're to say it in plain English, that's a person with a type of brain tumor that to date has no cure in the world. And that person is having surgery done on them again. Now imagine how that person is. Those are the type of people you're going to see. The second one, that's a person involved in a bomb explosion where he saw his friends die. He was thrown up in a car, and when he landed, he could not move his hands and his feet. And then he comes to you. That's the person you're talking to. The last one, the child doesn't know what's going on, but the mother, who tends to get encephaloceles. So we don't know the associations with hypoxia in utero, things about vitamin B12 and folate. But to her, she didn't know what she was going to get, and she's extremely stressed, and she just sees in the head. And those are the people that you meet, people who come in need. So if you're somebody who's comfortable with that, you should consider neurosurgery. If you're coming to be the boss and talk and you just want to sound like you're smart, don't come to neurosurgery because you won't be coming into their lives when they need you. And it's not about you, it's just about them. The next thing that I've shown you is it's technically challenging. Even the simple thing, which looks as simple as the glioblastoma, you saw to maintain something that we call oncofunctional balance, we use neurophysiology. And using neurophysiology, we try and check which parts of the brain are working. Now, for that, that's technically challenging in a couple of ways. Number one, you have to know which part of the brain that you're cutting. Next, you need to know if you cut this part of the brain, what's going to happen to the person. Sometimes it's simple and straightforward, like hemiparesis. Other times it's things like disinhibition, hallucinations. You need to know, you don't just cut and go. So it's technically challenging for every single thing. When it comes to spine, you need to know things about material science, biomechanics. Once you put this, how do they move? How should they exercise? It's not just doing the surgery and going home. And fun fact, if you don't know, the patient is coming back. So it's not a joke. It's something that you have to do and then you see. And the last thing, fascinating and complex anatomy. You tend to see placodes. You tend to see brain vesicles if they don't form properly. You try and figure out what's going on. Next, motivated and passionate colleagues. The one thing about neurosurgeons, all real neurosurgeons I know don't really care about being called neurosurgeons. In fact, the joke we keep saying, in all of the years we've been there, I don't think I've seen a graduation party done by any of the neurosurgical residents. Either they've been there for too long and everybody thinks they're already a consultant, or it doesn't touch them. They know what they've entered, they know what they're going to do. It's not the type of thing where you go, you're celebrating, you have mushinos, etc. People know what they're doing, they know the life that they've chosen, and then they're going to do it. Some might slip through who don't know, but most of them generally are passionate and relaxed, because every neurosurgeon I know is relaxed because you will see sad things every day. Now, if you're going to be touched every time you see something sad, you'll have a very short lifespan. You'll be very stressed. The last one is there are endless research opportunities. Now, and the simple example to give is we still do not fully understand the brain. We understand parts of the brain. We had anatomic somatotopic organization, and that completely changed. Things like the temporal lobe, if you come later or read neuroscience, everything has changed about somatotopic organization. We've learned it's about internal circuitry and different things like that. Why am I saying that? Because if you think about things like Neuralink and Elon Musk, it sounds like it's science fiction, but no, it's neurosurgeons, neurophysiologists, people who have to discuss, if you put this here, what is it that you're doing? What can you change? Now, if you don't understand anything about neurophysiology, neuroscience, it gets overblown. You think it's like, I don't know, Ghost in the Shell or anime or something. You think everyone is getting some weird thing where they're going to be able to do everything. But people forget, since the 1950s, we've already had brain implants. And I think all of you here already know one brain implant. And that brain implant is a cochlear implant. It's that simple. So if you have a function, what is the thing that you want to change? There are also different spine implants, there are pain implants. So there's lots of research opportunities, different materials, different metals, different things that you can do. And all of that is going on in neurosurgery. So if you're interested in that, you could even become a research neurosurgeon. But I don't think that's going to really work because one, you'll have to build the system without money. Two, you've seen there's still a lot of work from patients who are needed. So those are the advantages. What are the disadvantages? Man, it's clear. Number one, it takes time. It honestly takes time. It takes about 6 years in the beginning. That's provided you don't fail any year. Then after you do the 6 years, you may want to do a fellowship. And that's just for neurosurgery. When you start working in the real world, you might have to do other courses and other things which come as part of the thing. So it's extensive training. So if you like to read or if you like to learn, neuro is going to be fun. Second, long hours. There's no and ifs or buts about this. If the average workday is about 8 hours and the average case is 4 to 6 hours, what happens if you have 2 cases in a day? Now, to put it simply, people won't see you. People will get stressed. The other thing is everybody feels like they're entitled to your time. So if I have 2 people who are very stressed, having an emotionally tasking thing happening in their life, and I have to be there for them, but then you have somebody who's just going to who's going to get upset because they tried to call you twice and you didn't pick up, then your life is going to be strange. So you either have people who understand your lifestyle, or you'll have many people coming in and out. And there was a joke when I did one of my electives in neurosurgery as a postgrad. The joke was, everybody loves dating a neurosurgeon until week 4 or week 6, because then they realize they will never be number one in your time. Or there's another more macabre joke. How do you get the neurosurgeon to recognize his kids? Give him a CT scan. So, I mean, it's a bit of hyperbole, but the point is, when you're needed, you are needed. But to be honest, you won't be that busy all the time, but when you're busy, it's unplanned and then you disappear. And then, as you said, I just gave you 3 cases. In fact, I wouldn't even say any of those cases were sad until you see somebody going through it and you realize, oh, these things are real. But for some people, there's emotional discomfort in witnessing incredibly sick people suffer. You need to be aware. One of my, when I was in neurosurgery, one of the seniors told me something which stuck with me. You just need to remember you are not the one who gave them the disease. because sometimes you can personalize things. Can you do more? Can you do this? You give them the disease. All you can do is your best, and you can communicate at every point in time because it's the duty. It's what you've signed up to do. Okay. Now, after that pontificating, I'm about to pontificate a lot more in the last few minutes. How do you do it? Now, I'm going to say one simple thing, which I hope you remember. If you don't remember anything, please remember this. There is a difference between being one and being a good one. Repeat again. There is a difference between being one and being a good one. And this applies to anything you want to put your name to. And I say this because some of you will just be excited wanting to be a doctor. But you're not even focusing on trying to be a good doctor. The fun fact is, as long as you're trying to be good actively, you will be good. If you're just trying to pass exams, that's fine. You will pass exams. It doesn't mean that you're going to be good. The next thing is, what does being good mean to you? Does it mean that you're human? You care about patients? Does it mean that you're smart? Does it mean that you're reliable? Good has many different definitions, but you have to focus on trying to be good to be good. Do not focus on just passing exams and going to the next step, because at some point you'll realize as you were doing that, other people were trying to be good, and everybody gets their niche because good has very many definitions. And the same thing will happen in neurosurgery. You can pass all the exams, you can do everything, you can have all of the fellowships, and not a single patient will come to you because they don't think you're good. Doesn't mean that you're not competent. There's a difference between being good at something and being competent. So focus on being good. And I really thought, what can I tell you about this being good thing? So I thought if I'm speaking to undergraduates, I have to break it down, keep it simple. If you're in your end, you know it's called Dr. Magoha's rule. If I've taught you, I break everything down to 3 things to take home. And this is the part for the 3 things for you to take home. The 3 core tenets in how to become a neurosurgeon, you need these 3 things. Number 1, you need a mentor. You need a mentor. Why do you need a mentor? Now, mentorship means different things to different people. A mentor, I am not talking about movies, samurais. You're not going to come and sit and stand next to this person forever. The person ahead of you who has done what you want to do. And like I said, it has to at least be a surgeon in the field. I've told you 2. I've told you a neurologist and a neurosurgeon who helped me and guided me through neurosurgery. They told me the truth of what I have to do. That is what you need. If it's neurosurgery, if it's plastic surgery, if it's whatever it is, step 1, you stand up and you go to them. When you go to them, you ask them, how do I do this? What is the experience? And you will be shown opportunities beyond your wildest dreams. If they break your spirit, it's fine. There's another one. As we said, everybody will have personal relationships. They don't have to be fair because a personal relationship is a personal relationship. Some people will like you, some people will hate you. That is you learning. Okay, so pick a mentor in whichever field, ask them. Let them give you options. The more you talk to and you add your own personal initiative and your own personal experiences, they will give you different opportunities. So mentorship is important. And it doesn't mean that they're with you all the time. It might be a phone call twice a year. It might be a meeting once and they've changed your life. At this point, I told a story the last time and it cut. When I was looking to do my postgraduate, and eventually I landed on surgery. It's too long to say how I ended up landing on surgery. But when I landed on surgery, I wanted to go to University of Cape Town. So I started talking to my peers and I got so many stories, you know, racism, etc. People sending you YouTube links of somebody who suffered, you know, messages of how bad it's going to be or how I won't be able to make it. Just many different stories. When I went to my mentor, the late Professor Saidi, he asked me the simplest question, and it changed how I think. He just asked me, oh, you want to go to this place? Have you gone to them to ask how to enter? It's that simple. Then I was like, no, I can't fly to Cape Town. I can't do this. He laughed and said, is there a way to go there without flying? And lo and behold, I literally just sent an email. I Googled to see who the chair of surgery was at Crutuscure. I had been there for my electives before. He just sent me a message back saying, oh, he's ready to accept me as long as I fulfill 1, 2, 3. And he sent me what to fulfill. And that included doing the FCS, getting registered and coming. And then he wrote down there's another way to get in, which is if time is the issue, you can go to an accredited program, sit and pass your FCS in the first year, and then you can transfer in the second year to come do general surgery. That's when I wanted to do general surgery. And all of a sudden, I have walked around for about 2, 3 months talking to all the random people, and one simple email completely changed my mind. It blew my mind, realizing, oh, wait, the power is in my hands. It's not this story of everyone telling you. You don't have to know someone to do anything. Just send an email, ask, you will be told. Find out from the source. So, mentorship. Then number 2, this is what I just told you, erudition. You have to read. Unfortunately, there's no shortcut. Whatever you say, even if you say, like, here's the thing, I like AI. I love AI. I use it. To me, AI is just like saying using the internet. However, erudition doesn't mean having vast amount of knowledge. Erudition means understanding the knowledge which has been imparted to you. And the simplest example I can give any undergraduate student is this, because this tends to be a hard topic for most of you, biostatistics. If I ask you, what is p-value and its importance? You'll say p-value has to be less than 0.5. Otherwise, it's statistically significant. So you say that all the time. That's the thing which has been memorized. But every now and then, if I ask a student that, there's going to be one student who will be like, oh, p-value, first of all, it's called p-value because it's a value of probability. And it's a value of probability that what I'm looking at right now has a 1 in 20 chance of being due to chance. You see what that has done? They have paused to think about what they're reading. And the funniest thing, in all of your introductory chapters in every reference book, the introductory chapter says, as soon as you start understanding medicine, you will see the value of using medical language, because one word will completely describe everything to you. So focus less on memorizing, just start focusing on understanding. And if you understand basic concepts, you will build on top of them. And there will be nothing that can trick you. Like a nerve is only going to fire forward. When's it going to start firing in reverse? So you don't have to, if it's only going to fire one way, all of a sudden memorizing things is completely different. But wait, what if it fires in reverse? Simple. Immediately you know what that is. Where is it going to reach? That's a simple thing. So you must read. In whatever thing it is that you do, you must read. One thing which I have noticed is getting lost. It's not your volume of reading. Please, in anything you want to do, dermatology, internal medicine, general surgery, goes back to mentorship, ask them, what is the textbook I should read? Or when you tell to read that textbook, go and read that textbook. That being said, I realize this because we're doing exams. Many students don't understand the value of a reference book. So a reference book will be like Bailey and Love, like Nelson's for pediatrics. You know, the big book, the one you want to show that you're holding. Don't want to show your parents, you see, I'm smart. Those books are not meant to be read cover to cover. It is in their name. It is in the title. They are for reference. What does that mean to you as an undergraduate student? It means if you are given a topic in anything, you go, you open the reference book. In the reference book, you see the subtitles. In all of those subtitles, it tells you all of the important parts to know about the subject. Then from there, you go back to your syllabus. Your syllabus has things called core competencies. Your core competencies tell you how much you should read. A simple example is, let's take abdominal examination. If you're an idiot You probably have like MedBear or something pass, whichever thing that you want. I don't care, whichever one it is. You know those books that have lots of point form. And then you read a lot of those points and you're like, wow, I know. So you go and shine for your study group. If you do that, you might think you know abdominal exam. But if you read your syllabus, the core competency will say, student must understand the order of doing an abdominal exam. Student must be able to pick 3 of the following signs. I say that because you don't know this in undergraduate, or maybe some of you know. The abdominal exam for postgrad is a lot more detailed and complicated than for an undergraduate. The neuro exam for postgrad is a lot deeper and a lot longer than that of an undergraduate. So it's because you are not going to be a neurologist, you're not going to be a neurosurgeon, you are training to be a general practitioner. So read up to what you should know. You are never shining by reading more than what you should know. If this analogy is too much, the simplest example I can give is this. Most of you are on your phones or you're on your laptop. You can use it very well with efficiency for fun, for whatever it is. But I bet almost none of you know how to fix it. That is the same thing when you're reading a medical topic. You will not know everything about anything. Try Googling a drug. Googling a drug is different from being competent in pharmacology. Second thing, being competent in pharmacology is very different from therapeutics, because therapeutics is actually using it on people. Once you start to understand that at this level, reading in medicine will become a lot more fun because you cannot forget what you understand. And now the last one, if you want to be a neurosurgeon, practice. Now, for practice, it's simple. Distinguish interest versus real interest. And let me say this. Many of you are young. I'm presuming most of you are below the age of 25. Maybe some are above. I say that because of development of your frontal lobes. I'm not knocking you. I'm just speaking about science. I'm talking about risk assessment, analysis, control of emotions, and moving on despite feeling something. And during this period, you're forced to make some decisions. And I say that because if you see somebody who is good at something, you naturally want to be them or be like them. And if you do that, you might think this thing of, let me always try, let me always try. So we call that interest. And I was taught this by a cardiothoracic surgeon. And he is like, every time someone hears a cardiothoracic surgeon and they're anywhere close to medicine, they always come and say, hey, doc, I want you to mentor me. I'm like super interested. I want to be just like you. And then I used to think it was exciting when I was young. Then I just saw him say, yes, okay. Then after he pulled me aside, he said, you see that? That's called interest. That is not real interest. Let me give you an example of real interest. If you want something, what have you done about it? And the simplest example I will give is, he's not a student anymore. He's now a consultant neurosurgeon. This gentleman, you don't have to do this. This is just an example of what people do and they get in, whilst others just sit at home and come. This gentleman thought about neurosurgery. He came. He used to come do major ward runs in Kenyatta. He used to go and operate, and he had a logbook. By operate, I mean watch, ask to assist, do many different things. He wrote a formal letter. When I was in Aga Khan, many people used to do that in obstetrics, etc. And that's how they used to get reference letters. It's not that you just show up, hey, doc, I was in your class, give me a reference, I need it. What have you done? That is where the practice comes in. And as soon as you have practice, you have real interest. And I'll say this right now, as somebody who you've seen, you interview students all the time, you are not all approaching it the same way. Some of you just sit at home, I'll apply for this, let me read, I'll read at home, whilst others just go and start. So if you want it, go get it, prove everything wrong. And perfect example is one of my classmates after internship, during his internship, he kept a logbook of all of his obstetric procedures. Did anybody tell him to? No. It's because he was interested in OBS and he wrote it down. And at the time, he got into Aga Khan immediately after internship. And Aga Khan started before UON. And I say this because back in my day, everyone used to say, oh, you need to go and practice for like 3 years. I'm sure some of you are still being told that story by some of your lecturers. I didn't. I saw my classmate did it, same study group, and he got in. So I kept a logbook. I I applied immediately. In fact, I was still doing internship and I got in. I also told my other study group mate. So that's the point I'm saying. It's called real interest. We didn't get in because of any nonsense or knowing this. It's because even to date, if you ask me, I have that logbook. I can show you all the things I was doing during internship, all the extra time I spent. So by the time I came to the interview, we were literally just laughing. I was being asked, why are you interested in neurosurgery? I laughed. I said, wasn't I with you this morning at this hospital? Did I check up on your patient? By the way, their BP is this. So everyone started laughing because I don't have to prove that I'm interested. So practice in any field that you want. Start doing something. Another simple thing of practicing, read about it, publish about it, go work in a place. You do not have to be paid to practice. That's one thing you don't realize. You don't have to be paid to practice. And as soon as you show real interest, I would say 80 to 95% of people in the field that you want will do their best to help you. You just pray you don't find a bad one. Okay, now I finished pontificating. This is actually I haven't. I'm about to pontificate the most, but I'll make it short because we've gone over time. Let me know when I need to stop. We're on the last 10 minutes. Okay, then what? So what? You become a neurosurgeon and then you get lots of money, you get cars, you get the women or the men, you get your big family finally, whatever it is that you want. I don't know, because this is going to be different from everyone. I was blessed to grow up in a family of doctors who know other doctors, and there's one thing I will say. I don't think for any of them being a doctor defined them. After they finish, as my mom used to say, distinguish what you're doing to get regular, safe money versus what you are doing with your time and what you're doing for yourself. We're in a job where, or some of you are going to enter a job where in one day, you're going to passively do more good than what people who are not in medicine have to work like 1, 2, 3 years to even help someone. Think about it. Anything, even a child with diarrhea in this, somebody's going to have to raise money, do this, they have to tarmac and do what? You just have to go put the line, give the fluids, check up on the mom every day, but you've changed her life. And to you, that's just work. And I say that because sometimes it's easy to think that the job is going to entirely define you. And I say that because there's a risk. We are very few, so there's a tendency to get overworked because some places will be very busy. You will just be a cog. No matter how good you are, you'll be a cog. You will drop dead. They will put a nice picture. People will sign. Somebody else will be hired. That doesn't mean don't do your best. It means do not be sucked in too much. Do your best. Know when to stop. That's my advice I will give. Everybody will give a different thing. But what I will say is it's different for everyone. Some of you have skills from different places. You may know, you may not know. I used to draw. I still do. I draw, I paint. I do many different things. Other things I would say, some of them are personal for me and those who know me personally. The ones that I live out to the world, I live out to the world. And even with that, the things that I do for myself, I put some of it into medicine because I will put every single part of myself into something that I want and do the best. And that changes with different things. So that's why I said talking head time. So with that, I made this video yesterday for you guys to show you that you can do whatever you want. So I made a simple cartoon. I made it because sometimes I keep being asked the same questions and I'm incredibly lazy. I like systems. I can't do the same thing twice. Like I get extremely bored by it. So I kept being asked this question, what to do after craniotomy? Realizing they can just Google it, but they don't know or they don't trust the source. So I just made this video yesterday and I did it to also kind of motivate you guys today.
Congratulations. You made it through brain surgery. That's a major step. We're here to help you recover safely. The next few weeks are critical. Healing doesn't just come from medicine, it also comes from knowing what to avoid. Let's walk you through it. First, no heavy lifting. Avoid anything over 10 pounds. That's about 4.5 kilograms. This means grocery bags, laundry baskets, even picking up children or pets. Why? Because lifting can increase intracranial pressure. That's pressure inside your skull. and that can lead to serious complications. Instead, stick to light activity, gentle walking, slow stretching, or guided physical therapy. Your body and brain need time to heal. Next, no driving. Even if you're feeling fine, your brain is still healing. Your reaction time, coordination, and focus may be off. Avoid driving for at least 6 weeks or until your doctor says it's okay. In the meantime, use public transport, ride apps, or ask a loved one to drive you. Let's talk about food and drink. Skip the alcohol, limit the caffeine. Avoid sugary, fried, or heavily processed foods. Instead, fuel your brain with a clean, balanced diet. Fruits and vegetables, whole grains, lean proteins, and plenty of water. Ask your primary care team about speaking with a nutritionist if you need help planning meals. Then, stay away from crowds and avoid pesky germs. Your immune system is vulnerable after surgery, so avoid going to packed places and limit your amount of visitors. Clean your hands, clean spaces, and rest. That's your new normal for now. And don't forget your mind. Avoid stress, no doom scrolling, no noisy chaos. Give your brain the peace it needs. Try calming music, deep breathing, and simply sitting in quiet from time to time. Healing happens in stillness. Now remember, follow-up matters. Keep all of your appointments. That helps your doctors make sure everything is healing right. And watch for warning signs. A few of them could be severe headaches, fever, new onset confusion, trouble seeing or trouble speaking, fluid leaking from the wound. Call your doctor right away if you notice anything unusual. Remember, recovery isn't a race, so be kind to yourself. Avoid what could set you back and focus on what moves you forward. You've already done the hard part. Now let your healing begin. For more recovery tips, talk to your neurosurgery team. And remember, you've got this. Congratulations.
Okay. The other ones I can share, we've gone way past time. I'll share them to you. I just put them on social media, etc. All of them have different reasons to do, etc. But there's no agenda. Just I'm just enjoying myself. So you guys can enjoy yourself too. And the reason I say this is when you learn and you think globally, do what you enjoy with everything that you've learned. Use every skill that you've learned to be whatever you are when you finish. There's no defined path. There are many doctors, many consultants who are farmers, many are into tech, many have revolutionized and changed the world of medicine itself. It's not just people who are out there. We have people like Professor Saidi, we have people like Professor Ndete who died. We have the current, what do you call it, chair of FIGO. We have the current vice chair of the World Federation of Neurological Surgeons. Those are just people I'm acquainted with. There are many more who are doing, it's just that they might not be as loud. And I say this to inspire you because there is opportunity. So for everyone who is complaining, they haven't paused to look at what's going on, what's happening with the system, or more importantly, where can they change? Because if you stop complaining, you start seeing things that you can do. And as you keep doing, sorry, let's skip these because of time. As you keep doing that, you can do different things. So even now, after seeing different problems and different issues, we met up with a couple of colleagues and we started the Brain Tumor Association of Kenya. And this has done like a lot of work. It's helped a lot of people. I'm not going to say why or how because charity is not supposed to be for bragging. I was one of the founders and the initial Secretary General. Now I've left it with other people. Most of the other people have left except I think the chairman is still there now. But the point is, once you finish, it's your job to organize things which will help people. That is how you'll be empowered because we're so few and so many things are missing. All you have to do is see something that's missing outside, come organize and do it here. And you know the 30% rule. Yeah. For great change, you only need 1 out of 30 organized people to change everything. Go Google it, everything from civil rights to slavery. It wasn't mass. You don't need many people. You just need 1 out of 30. What does that mean? If there are 8,000 of you, actually, it's not about, it's simple. If you're in a hospital and there are 30 physicians in that hospital, you can change that entire hospital by being organized. And this is not fluff. It's not stuff to make you feel excited, etc. This is honest to goodness science, and it's been proven. So that's how you should think. If you want to do neurosurgery, fine, come. If somebody tells you you can't do neurosurgery, fine, prove them wrong. Simple. But when you prove them wrong, remember there's going to be life after that. So I hope that was helpful. We can defer to time, or I don't know if we're closing. I'll let the moderator tell me. So thank you. That's my name, Dr. M. Magoha. If you want to email me, this is my work email, mmagoha@unb.ac.ke. I was sent the slides by SlidesGo. Go join the site if you want. They've been really helpful to me. Yeah, you'll find this sign on social media. If you want to watch more of those videos, you can find me at the University of Nairobi. So I defer to the moderator.
Well, thank you so much, Dr. Magoha, for such an eye-opening and powerful presentation. It really showed us a bigger picture, and it really showed us what it is and what all neurosurgery means. We can now move on to Q&A. If anyone has any questions, you guys can raise your hands, and I can unmute you, and you can ask your questions. And you can always put your questions down on the chat box.
I have a question.
Yes, go ahead.
And before I ask, Dr. Mago, I just want to say thank you for the talk. It was really comprehensive and eye-opening, especially the part where you talked about the core tenets of being a good neurosurgeon and in extension, a good doctor. So my question was, what are the available training programs for neurosurgery